Hello, everybody. Good to see you, and thanks for joining. My name's Bradley Weiner. I'm a dual diagnosis specialist working at the intersection of developmental disabilities and mental health. And today's topic is how Ohio's behavior support rule works in the developmental disabilities system. Specifically, this is an overview for families and schools because the rules around behavior supports are different in the world of the developmental disability systems compared to schools and other things that families might be familiar with. I work at Rosemary, a residential provider, where I am the director of training, and I'm honored to be included. So, our objectives for today. Our objectives is for our attendees to be able to give examples of immediate risk of harm as described in the Department of Developmental Disabilities Behavior Support Rule, to describe situations where the behavior support rule may apply, and to be able to explain how the rule does or does not apply to your own personal role, be that as a parent, as a teacher, or as a professional provider. The rule may or may not apply. And if you are watching this live, absolutely type in your questions in the chat box. I'll be following along during the live presentation, answering the best I can. It's hard for me to address specific situations because I'd probably have to ask 10 or 20 questions if you're asking, would the rule apply in this sort of way to someone? You know, the details always matter. But hopefully by the end, either we'll have answered your questions or you'll know what direction to head to get the next level of what you're looking for. So some practical examples of how the behavior support rule comes up in day-to-day life. Things I've overheard. You know, they're saying that the rules mean that we can't lock up the food for our son in our own home. Could that possibly be true? Or, she struggles with doctor's appointments, and I want you to restrain her physically when she needs to get something medical done. Another example is a family saying, I don't want my kid gaining any more weight in that group home. Two more. If they, referring to a person with autism or other disabilities, if they understood the consequences of their action, they wouldn't need all these services. What do you mean it's their right? Who do I complain to? Or, I don't want my daughter dating, I don't care how old she is. Those are all very real examples illustrating very real concerns that families, friends, or other loved ones might have for people they care for that are receiving services. By the end of the session, we'll get back to those examples and see how the behavior support rule does and does not apply in Ohio in each of these today where we're sitting in 2021. So, the scope of the session today is to understand the basics of the rule and how it might apply to the people you know. The actual application of the rule is a pretty complicated thing. It's beyond the scope of today to teach everyone how to apply the rule and make sure that you're following all the details. We're just looking at the basics today. So, introduction to the topic. What we call the behavior support rule in the state of Ohio specifically governs the use of restrictive measures. Specifically, that means any sort of physical restraint, like a hands-on restraint of someone, or chemical restraint, or the use of a formal sort of seclusion, like a formal locked timeout room, or any situation in which someone's rights would be taken away. Now, in order to understand how the behavior support rule works, you really have to understand where the developmental disability system, the system that I myself work in, has come from and how we've evolved to this point. And most of it comes down to a history of institutionalization in the past of people who have disabilities and the various phases of deinstitutionalization. Understanding the rule requires understanding where it came from. So in history, perhaps you've heard of Willowbrook, or perhaps you've heard of the Apple Creek Developmental Center. Those are both examples of very old-fashioned institutional settings where people with disabilities used to live. Now, maybe you remember this yourself from your own history. My understanding is in the 1950s, 1960s, if parents had a child who had a disability detected around birth or early childhood, the doctor might tell them, the state will take care of them, forget about them, we'll take them to this institution. I've worked with families who have adults in their families. Like, I'm thinking of a woman who was in her 60s, and her sister was her guardian. And her sister would tell us, I remember going to visit her at the Developmental Center when she was little, and she would just sit and stare out the window, and they didn't understand what someone with autism was capable of than the way that we do now. And if you had told me that my sister would have hobbies and enjoy specific types of music and do specific sorts of crafts, I never would have believed you. And that's a really helpful, humbling reminder for me about where we came from. So it's important to understand that in that era, when our understanding of autism and other disabilities wasn't as developed as it is now, and I look forward to see where we're going in the future and what things people will be able to commonly do in 20 years that today we couldn't imagine. Anyways, when we remember what it came from back then, the job of the institution was to keep people with disabilities safe. And their direct supports were very much structured around safety above all things and adapting for the deficits. It's very common for folks who lived in the institutions or developmental centers. Mealtime comes, so you don't want people to get dirty. Everybody would strip their clothes off at the table. I worked with a woman who started her career on the night shift at Apple Creek, and she would tell me stories of remembering locking people in their rooms. Some other more disturbing stories. I know a guy who works in trauma right now who remembers in the early 80s a behavior support plan for someone with disabilities. It was his job to spray the person with water when they did certain target behaviors to disincentivize the behavior. That was what we knew to do then as a system. Now that we know better, we do better. So as these phases of deinstitutionalization have happened, not only have we physically deinstitutionalized where people live, bringing professional disability supports out into the community, we've also deinstitutionalized the approaches so that we're not trying to lock people up either literally or metaphorically. And this rule is part of a system-wide pivot in the person-centered services of people with disabilities. This is just one part of a whole pivot that's happening across the country and specifically in the state of Ohio about putting the person who's receiving services at the center of the work. I'd love to talk more about person-centered theory, but I guess that's another presentation for another time. So how I got here specifically totally ties in with understanding the behavior support rule. And if you're attending the Milestones Conference, you're learning about the absolute best, most cutting-edge information about autism out there. Perhaps you're in a similar situation to where I was when I first joined this professional disability services career. I had worked at the Monarch School for a few years as an associate teacher, and a lot of my training came from there, and I picked up all sorts of great things about how to understand visual communication and sensory integration, how people with autism see the world. And when I started working at Rosemary as a QIDP or case manager about 7 years ago, I remember the program director kind of showing me the files on the people I was working with. These were adults at the time, and here was a fellow who was having trouble waiting for the rest of the residents of his house to get ready to go to the workshop and get on the van. He was getting very anxious and having some aggression in the morning waiting for other people. And so, Bradley, you're the case manager, figure out how we're gonna solve this. And I remember, thinking with my autism training, okay, so yeah, we'll make him a visual schedule, show what's happening. We'll do some sorts of icons at the door about where we're gonna pause. So just show me where the Velcro is and I'll get started with the laminator. Because that's what I was used to, making visual supports for people. And no one knew what I was talking about. And I couldn't understand, what do you mean you didn't have a laminator? I didn't realize that the autism approaches that you hear discussed at places like a Milestones Conference are still cutting edge for much of the world. While they're the best practices now in the education world, in the DD system, the system of county boards, ICFs, and waiver-funded providers, it's still pretty new and cutting edge. So my own personal quest, this is a little bit of a soapbox, but that'll happen with me from time to time. My own personal quest has been sort of an ongoing push to get people in the developmental disabilities world learning from places like Milestones about all of the different things that are innovative supports for people with autism and other disabilities to do a more modern, more holistic, more purposeful approach of supports for people. As I get into talking about the behavior support role specifically, and some of the things that are and are not allowed or allowed only under certain circumstances, as you're listening to it, you might find yourself thinking, gosh, that's nutty. I can't believe that's the case. Do these people not understand the challenges that our loved ones have who are severely affected by autism? And I remember being right there with you. I remember when the email came out explaining the new behavior support rule. This was probably December of 2015, and the rule was going to be active in January. I had been at the agency for about 5 months, and I remember reading it and all the things and thinking like, oh my goodness, this is never going to work. Have you not met the people that I work with? Everybody's going to have these terrible accidents. And then I went to the training, learned about the rule, and started to embrace it. And one of the things that really I was honored to be a part of at Rosemary. Rosemary, the agency, was moving from a sort of old-fashioned approach to supports to very much embracing the modern person-centered approach that's at the heart of the behavior support rule. And when we in our work at Rosemary kind of got past just trying to meet the literal requirements of the rule and really embraced meeting the spirit of it as well, and really not trying to control people unnecessarily, that's when our work really took off, and we started to move from where we were in the past to an agency that's often pointed out as exemplary in using these sorts of approach for people with challenging behaviors. So a few months into it, I became a volunteer facilitator of a statewide workshop with the Department of Developmental Disabilities. We have regional workshops where other people in the field can come and polish their application of the behavior support rule. So my own journey from, wow, this will never work, what are you talking about, to, okay, now I'm facilitating workshops helping other people apply it, was about a year. And so if your reaction to any of this rule is, wait, that doesn't work, oh, I hear you. I had the exact same reaction too, and I hope that your experience of applying it is as positive as mine was. So, we're talking about a piece of the Ohio Revised Code specifically. When we say the behavior support rule, we're talking about Ohio Revised Code 5123-2206, titled Behavioral Support Strategies That Include Restrictive Measures, active in 2016. So literally, this is something that is part of the regulations of the state of Ohio. The text of the rule itself begins like this. Purpose. This rule limits the use and sets forth requirements for development and implementation of behavioral support strategies that include restrictive measures for the purpose of ensuring that 1. Restrictive measures are used only when necessary to keep people safe. 2. Individuals with developmental disabilities are supported in a caring and responsive manner that promotes dignity, respect, and trust, with recognition that they are equal citizens with the same rights and personal freedoms granted to Ohioans without developmental disabilities. 3. Services and supports are based on an understanding of the individual and the reasons for their actions. 4. Effort is directed at creating opportunities for individuals to exercise choice in matters affecting their everyday lives and supporting individuals to make choices that yield positive outcomes. And then the rule continues for a few pages in details of application. So for today's purposes, what does this rule mean? Well, here's what it means. At age 18, in the state of Ohio, people who have disabilities have the same rights of other citizens of the state of Ohio. And the bar to take away those rights is pretty high. Now, this pertains to what paid professionals are able to do, not to what families are able to do. So I want you to understand, if you're watching this presentation as a parent, This rule is not there to say that when your kid turns 18, you have to change the way you treat them as their parent. Absolutely not. This is not saying that somebody's behavior plan from school no longer applies when they're 18. No, this is specifically about professionals paid by the developmental disability system and what we are able to do. Now, the rule also understands that emergencies happen. We have a vibrant, robust, unusual incident reporting system in the state of Ohio, and it provides the ability to report what happens, when an emergency occurs. So, the unusual incident system in the state of Ohio is used to report when emergencies happen, and the behavior support rule says, for example, in a true emergency, say there's a house fire, and someone panics and isn't able to move. Their staff could go hands-on and use a transport restraint or drag them out of the house, and that's what's supposed to happen there in the state in an emergency. That doesn't need to be planned for in every what if. Emergencies do happen, and the emergency incident system can deal with them. Now, part of the rule also is that if we, the professionals, the frontline staff and behind-the-scenes staff working with the person receiving services could work harder up front to avoid having to use the restriction, the onus is on us to do so, even if it's inconvenient for us professionally, or if we have to work harder to prevent needing to use some of these restrictive measures. The assumption is we will do that rather than implement restrictive measures for someone. I'm going to give you some more examples of what that can look like. So, continuing on the idea of what it means. For a plan to restrain someone or a plan to restrict someone's rights to be put in place, there must be an immediate risk of harm or a likelihood of legal sanction. This is the key of the behavior support rule right here, this idea of immediate risk of harm. So, the line in order to take away someone's right to be free of restraint is if risk of harm to that person or risk of harm to other people is immediate. And similarly, there's also the idea of an immediate likelihood of legal sanction. For example, if a person is allowed to behave the way they are, they might lose their lease, be kicked out of their apartment, and become homeless, and it's an immediate risk. That is where the line is regarding rights restrictions and legal sanction. Now, the assessment of what it means to be immediate in that risk, also written in the fine print of the rule, the assessment needs to be done by someone who's qualified to do the assessment. Not just any of us can declare, see, the risk is immediate. Who can do it? A doctor, a psychiatrist, psychologist, a licensed social worker, a licensed counselor or marriage and family therapist, or somebody who is a BCBA, or someone who has a bachelor's degree plus 3 years of experience working with behavior supports. Woohoo, that's how I fall in there. So more of what does the rule mean in practical application. It also says that behavior supports need to be integrated into person-centered plans rather than segregated into their own approach. So in our world in the developmental disability system, if a specialist writes a behavior plan for the person, that has to be integrated into the rest of their supports. Now, the reason for this is, number one, in the past there were people who had more complex behaviors who were being segregated out of other programs by simply saying, we won't serve anyone with a behavior plan. And there's also levels of it where that supports the person-centered administration or the person-centered application of the supports. The idea that I don't treat you one way when you're acting nice and another way when you're having behaviors, it's all integrated. And because so much of what we do to prevent people from getting to that point of being violent or self-injurious is proactive, it really applies everywhere. So it requires that all of this is part of a person-centered team process, meaning that those of us who are members of the team are there to support the individual receiving services to live their life the best way they can, be the best version of themselves. Part of the rule is also that there is a human rights committee that oversees the process. They sort of, if the team is the legislature and the interdisciplinary team writes a person-centered plan saying this is the best way for this person to receive services and lead their best life, before it goes into action, if it involves a restriction, the Human Rights Committee says, yes, this meets the requirements of the rule, or no, it doesn't look like this meets the requirements of the rule. Now, something else in the rule is that, since this applies to people 18 and older, for children, an agency's policies and procedures can target doing things that are more age appropriate. Like, for example, a bedtime for an 8-year-old is totally age appropriate. We're not saying that 8-year-olds stay up and party. It's your right. How to do that is sort of a rabbit hole of policy and procedure. If you're interested in such a rabbit hole, email me because I like policy and procedure, especially when it comes to behavior support. And I can point you in the right contact person for your own county. So what it means, kind of getting into our interpretation about how the rule application works. I don't see it. It doesn't say, no, you can't do this intervention, other than a few prohibited measures like prone restraint, which is illegal in the state of Ohio. So it's not a matter of the rule says you can't do that. I think of it as the rule says for a paid provider, in order to do that, it would have to look like this: establishing the risk, reviewing to make sure there's data, oversight of a human rights committee, things like that. So it's not a matter of saying, no, you can't do this. It's if you have to do that, here's what it would need to look like. And the behavior support rule is always, at a minimum, looking for the team to work for someone to take their rights back. Part of the rule written says that none of these restrictions can last forever. There always needs to be some element where we're reviewing data to see if the restriction can go away, or even if that's not safe, how can the person work towards being more independent, getting their rights back in that area a piece at a time. Now, when it comes to the application, I kind of have to include this part just in the spirit of keeping it real. Sometimes it comes down to what I myself call a smell test. Does this smell like a restriction? Does this feel like the team is trying to control the person unnecessarily? And different teams could interpret the rule different ways in different situations. That's totally a thing. And the rule contains checks and balances, such as quarterly reviews, Human Rights Committee. They're built in order to provide that oversight. Okay, some specific examples to illustrate the impact and application of the behavior support rule. Now, the first example I like to provide, this is how the department trained us on this rule when it first came out, is different types of diabetes. You can, they use different types of diabetes to illustrate, well, when we say immediate risk, what does immediate risk mean? And I might get the details of diabetes wrong here. That's not really my thing, but thank you for forgiving me for doing my best. So some people with diabetes, if they eat certain foods, are going to have really bad health outcomes in a few years. They might end up in a hospital in a few years with all sorts of unpleasant things happening. There are other type of diabetes where if somebody eats something that's unsafe for them, they're going to land in the hospital today or tomorrow. According to the behavior support rule in the state of Ohio, the definition of immediate risk for that first type, where if I eat that sugary thing, I'm going to be in the hospital in a few years, that is not an immediate risk. If I eat that thing and I'm going to be in the hospital today, that is an immediate risk. So immediate isn't about the severity of it. It's about how immediately that risk could happen. So when we're talking about things like diabetes, high blood pressure, low cholesterol diets, those things are all recommended by doctors and dietitians for a reason, because there are serious health outcomes. If somebody who isn't eating a healthy diet continues to do so, they could have some really bad health outcomes in the future. So we don't just ignore it. The current take on it is The team's job is to educate the person on why the diet's important and how to follow it, and to provide environments, I would say, where it makes it easy for the person to succeed. And you can do that, and there's all sorts of ways to help a person make safe choices without taking away their ability to choose. Now, Prader-Willi syndrome is something that comes up often. There's certain best practices for Prader-Willi, which is a syndrome. And again, I'm not a medical person. I can only explain it. Here's the way I describe it to frontline staff is when someone has Prader-Willi syndrome, it affects your body's ability to know that you're full, know that you've eaten and are satiated, and the chemical to say, okay, you can stop eating now, you're fine, is not produced. And so someone with that syndrome often will just keep eating, to the point where it's really, can be fatal. And when somebody doesn't have the chemical to understand something or to process something, that's going to be an immediate risk forever. And so even though the rule says, well, these restrictions can't last forever, right? So in Prader-Willi's best practices, we're always trying to get that person a little more in control of their rights. Are there healthy foods that they could have unrestricted access to? And notice I'm saying it as a question. I'm not saying that's what people should do, but by looking at questions of that, are there times of day where the kitchen could be unlocked? Are there healthy foods that could have more access or a less limited access? The department behind the rule is always looking for people to be getting their rights back a piece at a time. So for things like recommended diets for health or other medical recommendations for a person, at what point is it a restriction? At what point are you taking someone's rights away by trying to get them to do something? So there's a flow chart we made to help determine this logic. And this is all in the rule, but a kind of a visual to apply it. So say a medical recommendation such as an altered diet comes up. An altered diet meaning somebody needs their food pureed or ground, or it's a choking hazard. And the question is, so is that a restriction? Is it their right to say no? How does this work? Well, if the person agrees and says like, okay, yeah, ground up food, whatever, not my favorite, but let's go with it. Go with the arrow on the left. Adopt the recommendation. It's not a restriction. And everyone will keep supporting the individual with education and understanding. Now, if the individual disagrees with that diet and says, heck, now when I say says, I mean either through their body language or their actual words, is communicating, stop cutting up my food. I don't want you to grind it into a pulp. I don't like that. Give me my whole hamburger, even though it's a choking risk. Well, the question comes, is there a direct or serious risk of harm per assessment on the right side of the chart there? Now, the flow chart continues. If you're really fascinated by that flow chart, take a look. We have it posted on the Rosemary website in our resources for providers section. I'm going to sort of jump to the end. Ultimately, it comes down to this, and this is another sort of my own language of helping frontline staff understand the behavior support role. If the individual receiving services says, I want that, and staff are going to have to say, you can't have it, or the person is saying, I don't want that thing, and staff are saying, but you have to, and that moment of physically preventing someone from having something or physically forcing someone to do something, then it's a restriction and the rule applies. I know a guy who needs his food pureed because of his inability to swallow, and it's really not a big deal. Even though the texture's mushy, he likes all sorts of food. It's not a big deal. If he reaches for something that's not pureed, his staff say, oh, hey, let me put that in the blender for you, and he sort of waits. He probably wouldn't recognize the danger without his staff there, but he waits, and it's no big deal. Now I know another guy who also needs altered diet for a risk of choking, and if he reaches for something, is more likely to grab it, shove it in his mouth, try to get it away from the staff, and start eating it, creating a really intense risk for himself. He really wants that food, and the assessment clarifies through his history, it's really dangerous for him to have it. So that's a situation where he is saying, I want, and his plan is for staff to say, no, you can't. That's very dangerous. Those are two different ways that the outcome of applying the behavior support rule can be different for a similar thing. So ultimately, it's these moments where the paid professionals are saying, you have to do this or you can't do that thing that you want to. That's where the rule applies. If it's less than that, if it's, come on, buddy, let's not do that, let's do something else, it's not technically a restriction, it's just part of the educational process of being a human. Okay, getting into the details of who the rule applies to. Because just because you're being paid for your professional services working with people with disabilities doesn't mean that this rule is written to apply to you. Specifically, the rule applies to county boards of developmental disabilities and all the services that they oversee. So that's the second one here. Providers of specialized services for people with intellectual or developmental disabilities. Generally speaking, that's referring to services that are funded by HCBS, home, or community-based service waivers. But there can be other funding streams for county boards, local support, for example, and the rule still applies because it's connected to a county board. Intermediate care facilities, which is a type of residential setting. At Rosemary, we run on a lot of ICFs, even though ours are smaller. The rule totally applies to us 100%. Generally, any professional who's in a role that receives oversight from the Ohio Department of Developmental Disabilities, the rule applies to. So those jobs are typically called DSP, Direct Support Professional. The case managers in that field are called SSAs, Service and Support Administrators, or in some counties, SAs. Often there are behavior specialists being funded by a waiver. I'm not talking about behavior specialists in school. I'm talking about your county board sends a behavior specialist into your home to come up with some strategies to help you work with your waiver providers. Those are all situations where the rule does apply. Now, people the rule specifically does not apply to are parents or family members, assuming they aren't also paid providers. Now, that's a real thing. There are many families who have realized that instead of paying people to continually come into my house, I can become a professional caregiver and provide these services rather than have to go get a job and let's try again. So people the rule specifically does not apply to parents or family members, assuming they aren't also paid providers, because there are some people who do receive developmental disability systems money to support them caring for their family members in home. If they're getting paid by the system, they are a professional, and the rule applies. But that's not what we're talking about right now. When I say family members, just like as a family member of someone who is not also a professional support, this rule does not apply to you. It is not the Department of Disabilities' business to tell you what you can or can't do in your home when it comes to behavior supports under the guise of this rule. The rule also does not apply to medical professionals other than those that are employed by a provider agency. So, for example, I work at Rosemary. We operate ICFs, intermediate care facilities. Those intermediate care facilities employ nurses, and we employ direct support professionals. If we take somebody to an emergency room and the doctor and nurses who work at the ER do some sort of restraint to help that person get a blood draw done or get an injection, the behavior support rule doesn't tell those doctors and nurses what to do because they work at the hospital. But the nurse that works for us in the ICF, the rule does apply to her. So generally speaking, medical professionals, unless they're working for the agency, the rule does not apply to them. Hospitals and nursing homes are not under the scope of the rule. They all have their own rules and probably do have specific regulations about under what situation it's appropriate to do something that is restrictive to a person's rights or a physical restraint, but that's not this particular rule. Also, this rule does not apply to schools. And there are schools where the school and the County Board of Developmental Disabilities work together, and that's its own can of worms that I'm not able to get into specifically. But the education system, if you're talking about something that's under someone's IEP and funded by their IEP, that's the education system's rules are going to apply there, not the developmental disability system. Now, if you're trying to figure out if the rule applies in a situation, I say when in doubt, look to the funding system. If it's funded by the DD system, rather than by, say, the education system, or the mental health system, or children's services, or a hospital. If it's not those things, if it's funded by the DD system specifically, the rule probably applies. Okay, we have a good chunk of time now to go through some specific examples, which will allow us to look at some specific application, little corners of it that we haven't talked about yet, as well as revisit some of the ideas that we've talked about and see how they work in real life. Okay, example number 1, locking up food for an adult receiving professional DD services when the concern is weight gain. So the question is it an immediate risk of harm? Generally speaking, weight gain isn't the sort of thing where if you eat too many calories, you're going to end up in the hospital tomorrow. If the person has some sort of specific medical condition that makes that the case, that's entirely different than just general weight gain. If the question is locking up food because the person is heavy and all of the health risks that come with being overweight in general, those are not an immediate risk of harm. So any supports around portion control or food selection for that person would need to be non-restrictive because there is no immediate risk of harm. So there's all sorts of things you can do in that situation. You can use your full gamut of skills to teach that person to make better choices. You can support them to make better choices. You can carve an easier path for them. If the person's really struggling with weight and they've shown that they have no ability to control themselves around, say, Girl Scout tag-along cookies, I could be talking about myself. Maybe I'm not. We'll see. Anyways, if that's the case and the person can't control themselves around delicious, delicious tag-along cookies, you could make an easier path for them by just not keeping piles and piles of tag-alongs in the house. And if the person gets to the point where they say to their professional staff, listen, tag-along cookies are really important to me, and when you go shopping, I need you to buy them, or even better, when we go shopping, we're going to get some, as that person's, if you're that person's support staff, you can say, all right, we're gonna get some tag-along cookies, and I also wanna show you this cool recipe about peanut butter and celery, and 7 other healthy options. The idea is you're carving a supportive path with the person and doing all sorts of things other than saying, no, you can't, if it's not an immediate risk of harm. Okay, now let's apply that to a child. Remember, at the center of the behavior support rule is, in the state of Ohio, adults, whether they have disabilities or not, have certain rights. And in the state of Ohio, adulthood happens at the age of 18. So locking up food for a child, the child doesn't have the same rights as an adult to say what they want. And this is kind of getting into the niche of the behavior support rule, but in that niche application, agencies can write policy and procedure that makes the rule apply age appropriately. So when you're doing that age-appropriate application, it looks something like this. I'm going to kind of borrow a few beats from how I do frontline staff training around this issue. So what we try to do for kids is age-appropriate restrictions when it comes to food. So imagine you've got an 8-year-old who it's almost time for dinner, and they've already had snack, and they're going into the pantry and getting a bag of Doritos. What is an age-appropriate way to support that 8-year-old to make a healthy choice with those Doritos? Most people at this point probably say, oh, I'd get a bowl, and either have them pour it into the bowl or pour it for them and say, sit down, I'll get this for you. For an 8-year-old, oh yeah, age appropriate, great. You could even say for an 8-year-old, no honey, dinner is in 1 hour, I'm gonna put this away, let's go play our favorite game while someone else makes dinner, something like that, a positive redirection. So what could that look like for a 16-year-old? 16-year-old's already had snack, going into the pantry, about to crack open the whole bag of Doritos. What's an age-appropriate way to support that? I had a Dorito habit when I was 16. I used to go through, it wasn't a full-size bag, it was about this big, and it was always, for some reason, with orange soda. And it was excessive, and sometimes 16-year-olds do excessive things. Now, if it's a 16-year-old who's got some significant health concerns that aren't an immediate risk of harm, you could still pour it out with them, say, hey, can I put that away for you? That's great. But you're not going to approach it as heavy-handedly as you would for an 8-year-old. Now, what about when that same person turns 18? How could you support them? You could do all of those other non-restrictive things, say, let's pour out a little bit together, or say, let's wait till dinner. You're not going to say, no, you're not allowed because you're overweight and it's time for dinner if that person is 18, unless there's an immediate risk of harm that's gone through the behavior support rule. Okay, example number 3. The question of physical restraint by a phlebotomist for a blood draw. This is a really interesting thing if you if you enjoy the details of applying behavior support philosophies. And if you don't, thank you for joining us on the adventure anyways. So there are a lot of people who need their arms stabilized in order to receive a blood draw. Say somebody has cerebral palsy or tardive dyskinesia and can't hold their arms still, and their staff need to hold their arms still in order to safely get a blood draw. Absolutely, their staff are going to do that. In fact, it doesn't even need to go through the behavior support rule, because if it's just about stability, if it's just a matter of help me hold my arms still, and that person's not willfully pulling away, it's not about behavior. It's just that's a support that person needs because of their physical disability. Now, that line of about behavior and about physical disability, well, doesn't the behavior come from a mental health diagnosis or from autism? That could be a side effect of a disability. Oh, yeah. That gray area is quite generous. When you're talking about somebody willfully pulling away from something, that's when we look at it as an intentional behavior as opposed to a support for a physical disability. So, back to the blood draw idea. Just staff stabilizing someone's arm for safety doesn't even apply to the topic of behavior supports. Now, if that person is nervous about the blood draw and the staff start to hold their arm down and the person starts to pull away, I'm not going to, if I'm helping somebody and there's I'm sorry, I'm going to get a little medical here, so if you don't like hearing about needles and stuff, plug your ears. If there's a needle going into someone's arm and they start pulling away, that's a really risky thing, and I'm going to hold on to that person's arm if I'm helping them. And if I need to write an incident report for an unapproved behavior support afterwards, that's what I should do in that situation. If we're going into a situation where we know that person is going to struggle, we can get into the weeds here, but hey, here we are, let's get into the weeds. If it's a really important blood draw, you could look at it as an immediate risk of harm. You could look at it as an emergency. You could look at it as, if we don't get this Depakote level today, the next time this person has a mental health crisis, the psychiatrist isn't going to know where to go. Like, there's all sorts of ways you could tie that to risk. And we're now in the gray area, and the details matter, and what the team decides with oversight from the Human Rights Committee, there's a few different ways you can go. Again, you're looking for immediate risk. Oh, and we're in the weeds. I'm going to jump out of that one. Ooh, one more thing. If the phlebotomist themselves or the nurse who works at the doctor's office is holding the arm, even if the person's willfully pulling away, the person doing the holding is not a paid developmental disabilities provider, the rule does not apply to them. Okay, next example. Parent who is also a paid provider. This will happen sometimes where rather than the parent, go to work and pay someone else to provide for their child, and this could be a child or an adult child, to pay someone else for their child's needs, sometimes a parent can go into the business of being a paid provider and follow all of the rules that go along with billing and everything else having to do with the DD system, and provide services for their own family member in their own home. There's a full-time version of that called Ohio Supported Living, which has been a really good fit for a lot of people. So in that situation, that parent has a dual role where, yes, they are the parent and they are also the paid provider. Anytime they're a paid provider, all of the behavior support rule applies. So that just is what it is. If you are, just the same as all of the other rules of being a developmental disability provider apply when you are that parent. So if you do have that dual role, anytime you are in provider role, you are following the behavior support rule. Okay. Lastly, let's look at some examples involving seatbelts. Now, when I think seatbelts, in my world at work, I see seatbelts in two different situations. One, seatbelts in a car, and two, seatbelts for people who use wheelchairs. Often a person will have either a seatbelt or some sort of seatbelt with a chest harness for safe positioning and posture. So, heck, let's talk about both of those. The overarching philosophy that's going to apply here is a seatbelt used for its intended purpose, the same way somebody who is not receiving developmental disability services might use a seatbelt, is not under the oversight of the behavior support rule. That's just life happening. So, when somebody is riding in a car wearing a seatbelt for safety in the car, the behavior support rule question doesn't go there. What about somebody who doesn't want to wear a seatbelt in the car? Well, unless you're physically forcing that person into the seatbelt or physically preventing the seatbelt from undoing itself, the behavior support rule doesn't apply. If you are, there are situations where for transportation safety, somebody needs something that prevents a seatbelt from opening. That in those situations, the behavior support rule does apply, and the question of risk of harm is there, and there are ways to meet that need. Everything that we've talked about will apply. Thinking about a wheelchair seatbelt, that person's wearing a seatbelt in their wheelchair for posture to make sure that they're able to sit up straight, not hurt their back, not choke, breathe everything. Behavior support rule doesn't apply. That is the seatbelt being used for its intended purpose. So, what if the seatbelt's being used for behavior? Well, if someone's in a car, everybody wears a seatbelt in a car. So let's not use the car example, let's use the wheelchair example. If somebody is using a wheelchair to get around and their paid staff are putting a seatbelt on that person to prevent them from standing up and falling. Let's see, if it's the matter of preventing the person from standing up, even if it's because that person doesn't understand their own fall risk, if you're using the seatbelt to prevent the immediate risk of that fall, it does sound like that seatbelt is being used to control a willful behavior, and the behavior support rule would apply. The question is it an immediate risk of harm? So if the risk is a fall, broken hip, oh, that's a very immediate, very bad risk of harm. If the risk is the person will get out of their chair and get into mischief, and then the staff won't be able to continue cooking dinner and it'll be interrupted, probably not an immediate risk of harm. So generally speaking, if you are using things like a seatbelt in a wheelchair to control a person's willful behavior, you're going to want to put it through the behavior support rule. Okay, finally, we have arrived back to where we began. Let's revisit those handful of examples we talked about at the beginning and see how the behavior support rule does or does not apply. So a parent saying, they said that these rules mean that we can't lock up food for our own son. Is that true in our own home? Well, unless the family is also a paid provider, no, that's not true. We said the behavior support rule only applies to paid providers of services in the DD system. So only if the family is also a paid provider. One other thing, notice the second part of this sentence here, or if waiver-funded providers are dealing with food in the home. If you have a waiver that's bringing direct support professionals into your home, when those direct support professionals are working, the rule does apply to them, and that could affect how things that are locked might have to become unlocked if that's part of what they're dealing with when they're there, because they're providing services and they need to go by the behavior support rule. Okay, another example. She struggles with doctor's appointments. I want you to restrain her when she needs something medical done. Well, how will this apply? The first thing we're going to do is to try teaching the person, sometimes they call it desensitization, helping the person understand, social stories, reinforcement, all of the things that you do that are less traumatizing than holding someone down for medical things. And we're going to recognize that if an emergency does happen, we will go hands-on to support that person. That's a huge part of our training as paid providers. But overall, to just say, because someone struggles with doctor's appointments, we're going to restrain someone for all medical things, until there's an immediate risk of harm, we're going to look at it differently. And this is a great example of we as providers are going to have to work harder to teach somebody to safely participate in medical appointments. We're going to work as hard as we can on that before we start to do any sort of hands-on intervention. And if an emergency happens, we're going to deal with that emergency with hands-on if need be. Okay. Example, I don't want my kid gaining any more weight in that group home. So if they're an adult, we're going to talk about how we can teach healthy living skills and what could help them value that part of their own health. For example, you want to live a long time so that you can keep doing the things that you like. You want to maintain a fit body so you can have the energy to go places, whatever that quality of life means to that person. And if it's an adult, just because the parents don't want them gaining any more weight, my parents probably wish I'm not gaining any more weight too, but I've been in the middle of a pandemic and I'm doing the best I can. And people with disabilities have the same rights as other Ohioans when there isn't an immediate risk of harm involved. Okay, revisiting. Oh, this is a big one. If they understood the consequences of their actions, they wouldn't need all of these services. What do you mean it's their right? Who do I complain to? I got you for all of that. If they're 18, it is their right, minus an immediate risk of harm or immediate likelihood of legal sanction. This is part of the Americans with Disabilities Act. This is part of the Olmstead court decision, trying to give people with disabilities the right to make the same bad decisions as the rest of us. The question of who can I complain to, I direct you to the Department of Developmental Disabilities Family Advisory Council, who participate in the writing and rewriting of all of these rules at the link you see on the screen here. This is a thing that comes from Columbus, and so on one hand, fighting City Hall, there's an expression about that, but on the other hand, if the rule isn't working for your family, your feedback can help fix the problem. The good news from my perspective as a professional is every situation that I've seen where we weren't sure how to meet someone's needs under the behavior support rule, we figured it out. Remember, it's not a matter of saying, no, you can't do that. It's a matter of, if this needed to happen, here's what it would look like. Okay, revisiting. I don't want my daughter dating. I don't care how old she is. The law in this situation is pretty darn clear. Actively preventing an adult from dating because that's what the family wants is not a service that we can provide as paid providers. Now, helping to prevent someone from doing dangerous things is a service we can provide. And we would follow all of the processes in the behavior support rule to support that need. So to just say, no, she's not dating because she has a disability, that's not a service we as professional providers can apply in Ohio. But if we're really concerned about safety and someone who doesn't understand the potential for other people to not have good motivations and the danger that goes with all of that, now that's something we can work on. And like all the other things, we as providers would have to work hard to help that person learn before we would even talk about creating some sort of restrictive plan for that person. So thank you so much. Thank you so much for having me here. Participating in Milestones has always, for the past few years, been just a highlight of the year, and I'm always honored to be a part. There's my email address if you want help pointing in any of the right directions for the people in your own life. I do want to say a couple things. The references here, The first reference there is the text of the behavior support rule itself. The MIIDCCOE of Ohio is the Mental Illness, Intellectual Disability Co-Coordinating Office of Excellence. I might have gotten one of the C's wrong. In the state of Ohio, that is the office that coordinates between the Department of Developmental Disabilities and the Department of Mental Health and Addiction Services. And the website that they maintain has a bunch of official training materials, frequently asked questions, links to all of the webinars when the behavior support rule worked out. If this is really something you're passionate about and want to learn more about, those webinars are the exact same training that those of us in the field got when the behavior support rule was rolling out. So you can see the people from the state talking about these things directly, answering those questions. This link here is really interesting, public comments during the rule formation. Something that I've seen as being a part of the developmental disabilities system in Ohio for the past few years is when a new rule is happening, there's a public comment process, and those get preserved. So if you're someone who's really worried about some of these things, I wouldn't be surprised if there are other people who, when the rule was coming out, had the same concerns. So you can see what they said, what the official response from the Department of Disabilities was, and therefore maybe that led to part of the change in the rule or what their thoughts were. And it's nice, that way you can hear it directly from them. You know, I don't work for the department, I just am someone who they oversee, and I've learned to work with them, so that's a really great way you can get it more directly. And for professionals, this Rosemary link here, we keep there's a zip drive from a training series we did, or excuse me, a zip folder from a training series we did on the professional resources part of our website. So if you are in the developmental disability system or want to see really how we train providers on that, there's how to do it. Thank you so much for spending this time. If you were watching live, I hope I was able to type appropriate answers to all of your questions. If you're not watching live, I really appreciate you taking the time anyways. And thank you to Milestones for hosting and for the invitation. And I'll see everybody around. Take care. Bye.